Welcome to the deep dive. Today we're your Naplex navigators.
That's right.
And we're going to chart a course through these challenging waters of anticoagulation for VTE.
Absolutely.
You guys shared some awesome resources with us. So we're really excited to dive deep and extract all those Naplex-worthy nuggets.
Yes.
That'll make you feel so confident when you see a VTE question on the Naplex.
That's the goal.
Yeah.
I think what's really fascinating about VTE is that it's not just one condition.
Right.
It's an umbrella term that covers two really serious conditions.
Okay.
DVT and PE.
Okay, so let's unpack that a little bit more.
Sure.
So we've got DVT, which
Yeah.
is that clot that forms in the deep veins, usually in the legs.
Exactly.
And then PE is when a piece of that clot breaks off,
Right, yeah.
travels to the lungs.
Exactly. And that's where it becomes really clinically significant because a DVT can lead to a PE,
Oh, wow.
which can be life-threatening.
Yeah.
But even if a DVT doesn't progress to a PE, it can still have some pretty serious long-term consequences, like post-phlebitic syndrome.
Oh, wow. I've never even heard of that.
Yeah, it's chronic pain, swelling, and even ulcers.
So we're not just talking about like a temporary inconvenience here.
No.
This is like serious stuff.
Yeah, this can have lifelong implications for patients.
Definitely makes sense why it's such a hot topic on the NADPLX.
For sure.
But before we jump into treatment, I'm curious, how do these clots even form in the first place?
Well, it's usually a combo of different factors, and we can kind of think about it like Virchow's triad.
Virchow's triad, okay.
Yeah, so that's venous stasis, vascular wall injury, and hypercoagulability.
Virchow's triad. I feel like that's like bringing me back to pharmacy school.
Back in the day.
Can you break down each of those factors for us?
Absolutely. So venous stasis, that's all about slow blood flow.
Okay.
And that can happen for a variety of reasons, like after surgery or if you've been on a long flight and you've been immobile for a while.
Makes sense.
Vascular wall injury could be from some sort of trauma or even something as simple as an IV catheter. And then hypercoagulability, that just means the blood is more likely to clot.
Okay.
And that could be due to things like genetics, pregnancy cancer, or certain medications.
So many different culprits.
Right.
It seems like recognizing those risk factors in a patient case would be like a key first step for like those anti-PLX questions.
Absolutely. And that's where our understanding of these anticoagulants comes in.
Okay.
Because the goal is to prevent clots from forming,
Right.
or if a clot has already formed, to prevent it from getting bigger and causing more problems.
Okay, so let's dive into the world of anticoagulants.
Let's do it.
From what I remember, there's a few different categories, right?
You got it.
Help me refresh my memory.
So we have the indirect thrombin inhibitors,
Okay.
which include heparin LMWHs, so those are the low molecular weight heparins,
Okay.
and fondaparinux.
Fondaparinux. Okay.
Then we have the direct thrombin inhibitors,
Okay.
like argatrobin, bivalirudin, and dapagliflozin.
Okay. And then last but not least,
Yep, the veteran of the group.
Warfarin.
Warfarin, the vitamin K antagonist.
All right. That's a lot of names to keep straight.
I know, right?
Can we break down each category a little bit more?
Excellent.
And kind of see how they work their magic?
Sure.
Let's start with those indirect thrombin inhibitors.
Okay.
What's their mechanism of action?
They kind of work indirectly, as the name suggests,
Yeah.
by activating antithrombin, which is a natural inhibitor in our bodies. And antithrombin then goes on to inactivate those clotting factors,
Okay.
primarily thrombin, which is factor TIA,
Okay.
and factor VESA.
So they're like the puppet masters behind the scene controlling this whole cascade.
Exactly.
Heparin and LMWHs both fall under this category, right?
You got it.
Is there a difference between the two?
Yeah, both work through that antithrombin.
Okay.
But LMWHs have a stronger affinity for factor ISA,
Okay.
making them a little bit more targeted in their action.
So it's like a sniper versus shotgun approach.
I like that analogy.
Does this difference in their mechanism have any practical implications for how we actually use these drugs?
Definitely. So with heparin, we need to be much more cautious about the risk of bleeding.
Okay.
It requires close monitoring, usually with the APTT or the activated partial thromboplastin time,
Right.
or we look at anti-ZEC levels.
Sure.
LMWHs, on the other hand, are more predictable
Oh.
and generally don't require routine monitoring.
So that's a win for LMWHs in terms of patient convenience.
Definitely.
No constant blood draws.
Right. No needles.
What other perks do LMWHs have?
Another big plus is that they can often be given at home through injections,
Okay.
whereas heparin usually requires hospitalization for that continuous IV infusion.
Interesting. I'm already starting to see how these subtle differences can really like influence treatment decisions.
For sure.
Especially in those Nuntiasis case studies where they're really trying to get you on those little details.
Absolutely.
But I remember learning about like a scary complication with heparin.
Oh, yeah.
Something about HIT.
HIT, heparin-induced thrombocytopenia.
Okay.
It's rare,
Okay.
but it is a very serious immune reaction
Yeah.
where the body produces antibodies against heparin.
Okay.
And the worst part is that this drop in platelets
Yep.
can actually increase the risk of clotting.
Wait, so the drug that's supposed to prevent clots
Yeah.
can actually make them more likely?
Yeah, it's kind of counterintuitive.
That seems counterintuitive.
And it's a real thing.
What should we be looking for in a patient to suspect HIT?
So the hallmark sign is a significant drop in the platelet count,
Okay.
usually 50% or greater
Okay.
after they've started heparin.
Okay, so if we see that red flag, HIT should be like top of mind.
Absolutely, red flags are crucial.
What happens if a patient develops HIT? Does that mean they can never use heparin again?
If it is suspected, we need to stop it immediately.
Right.
But luckily, we have other anticoagulants that
Then-
don't cross-react with heparin and
Right.
don't carry that HIT risk.
Okay, so we've got options.
We do.
What drugs are we talking about?
So in the case of HIT, we would switch to a direct thrombin inhibitor,
Okay.
like argatroban or bivaleritin.
Okay.
Or we could use fondaparinux,
Okay.
which is a factor Xa inhibitor like the LMWHs.
Okay.
But it's given by injection, not orally.
Fondaparinux, that's a good one to remember.
Yeah, definitely.
Okay, so we've covered LMWHs, fondaparinux.
Yep.
Let's move on to those direct thrombin inhibitors,
Mm.
the DTIs. How do those work? Do they also activate antithrombin?
They're a little more straightforward.
Okay.
They directly bind to and inactivate thrombin.
Okay.
So we kind of bypass that anticoagulant altogether.
No middleman.
No middleman needed.
Simple to the point. I like it. Are there any specific situations where you would choose a DTI over an indirect thrombin inhibitor?
Absolutely. Like we just discussed, argatroban and bivaleritin are our go-to choices when a patient develops HIT. They're both given intravenously, and they require APTT monitoring.
So they step in when heparin is out of the picture.
Exactly.
Got it. Now what about dabigatran? That's the oral DTI, right?
That's right. Dabigatran was a game changer when it came out.
Yeah.
It's the only oral DTI and can be used for a few different things, including stroke prevention and atrial fibrillation.
Right.
And the treatment of VTE.
I remember it being a big deal because it didn't require that routine monitoring.
Exact.
That must be huge for patients.
Absolutely. No more frequent blood draws to
Okay.
check INR,
Yeah.
so that convenience factor can really improve medication adherence.
Right. Which is good for everybody.
It's a win-win.
Okay, so we've got our indirect thrombin inhibitors. We've got our direct thrombin inhibitors.
Yep.
What about the old standby warfarin? It seems like it's been around forever.
It has, and it's still a very relevant option.
Okay.
It works a bit differently than the other anticoagulants we've talked about.
How so?
It's a vitamin K antagonist,
Okay.
meaning that it blocks the synthesis of vitamin K-dependent clotting factors.
So instead of directly going after thrombin,
Right.
it's working upstream to prevent the production of several key clotting factors. You got it.
What clotting factors are we talking about?
Think of it this way. Warfarin is like an overzealous editor slashing the production of factors 2, 7, 9, and 10.
I like that analogy.
They're all vital for the coagulation cascade, and without them,
Right.
clot formation is significantly hampered.
So how does warfarin compare to the other anticoagulants in terms of how quickly it works?
That's a key difference.
Okay.
Unlike the others we've discussed, it takes several days to reach its full therapeutic effect.
Oh, so it's not a quick fix.
Not a quick fix.
What happens in those urgent situations?
In those situations, we often bridge therapy by starting warfarin
Okay.
alongside a parenteral anticoagulant like heparin or an LMWH.
Okay.
We monitor closely
Right.
using the INR, the International Normalized Ratio.
Right.
And once warfarin reaches that therapeutic level,
Okay.
then we can safely discontinue the parenteral agent.
So it's like a tag team approach.
Yeah, a little teamwork.
I remember warfarin having a reputation for being a little bit tricky to manage.
What makes it so challenging?
It has a narrow therapeutic index,
Okay.
meaning that the dose needs to be carefully individualized,
Oh,
and lots of things can affect its effectiveness.
oh, what?
Diet is a big one,
Okay.
especially foods rich in vitamin K,
Okay.
like leafy green vegetables and liver.
Are there any visual aids that could help patients remember the different strength and their corresponding doses?
Absolutely. They come in color-coded strength,
Okay.
which is really helpful for both patients and pharmacists
Okay.
to make sure the right dose is being dispensed.
And taken. Okay, that's a great mnemonic. I'm a visual learner, so I can definitely see how that would be helpful.
Yeah.
Speaking of mnemonics,
Mm-hmm.
with so many different anticoagulant options,
Right.
how do we even begin to choose the right one?
That's the million-dollar question.
Yeah.
And it's a crucial one for the NEPLX.
Right.
But the good news is that we have evidence-based guidelines, like the CHEST guidelines, to help us navigate these choices. They recommend DOACs as the preferred option
Okay.
for initial VTE treatment in most cases
Fine.
because they have a more favorable safety and convenience profile.
Okay.
But warfarin might be a better choice for certain patients,
Like who?
particularly those with severe renal impairment
Okay.
or a history of GI bleeds.
Okay, so it's not one size fits all.
Exactly.
We really got to consider each patient,
Right.
their risk factors and their comorbidities to make the best decision.
Absolutely. And don't forget about cost.
Right, of course.
Warfarin is significantly cheaper than the DOACs.
Yeah, that's a real-world consideration. That's a huge factor, especially for patients that don't have insurance coverage.
For sure.
For the newer agents.
Absolutely.
Okay, this is why I love pharmacy. It's like the perfect blend of science and patient care.
It is.
Before we move on, let's do a quick recap of what we've covered so far.
Great idea.
We started by defining VTE,
Yeah.
which includes DVT and PE.
Yep.
And we talked about Virchow's triad. Those three key factors that contribute to clot formation.
Exactly. And then we delved into the different classes of anticoagulants, starting with the indirect thrombin inhibitors like heparin and LMWHs, which work through antithrombin.
Exactly.
We also touched on fondaparinux, our unique factor Zaza inhibitor that's given by injection.
Right. Then we discussed the direct thrombin inhibitors, highlighting their straightforward mechanism of directly targeting thrombin. Argatrobin and bivalirudin kind of emerged as like the heroes in the setting of HIT.
Absolutely.
While dabigatran stood out as the only oral DTI with that convenient fixed dose regimen and no need for routine monitoring.
For sure.
And we wrapped up our anticoagulant overview with Warfarin, the veteran of the group.
Definitely.
Which works by inhibiting the synthesis of those vitamin K-dependent clotting factors.
Exactly.
We emphasized its narrow therapeutic index that delayed onset of action. And the importance of monitoring those INR levels, along with patient education about diet and potential interactions.
Super important.
Okay, now I know we've been focusing on the drugs themselves, but managing VTE goes beyond just picking an anticoagulant.
For sure.
There's a whole world of drug interactions that we need to be aware of.
Oh, yeah.
And I have a feeling this is where things can get really tricky.
It can.
Especially on the NAKLX.
Absolutely. Drug interactions are a major consideration with these medications, and they can significantly impact both the safety and the effectiveness of therapy.
So high-yield material for the NAPLX.
For sure, high yield.
Okay, then let's dive into that next. Where should we start? Which anticoagulant has the most potential for interactions?
Let's start with warfarin.
Okay.
Remember how we talked about warfarin's metabolism being affected by those cytochrome P450 enzymes?
Yes.
Specifically CYP2C9?
Yes, CYP2C9. I remember that.
Good.
It's responsible for metabolizing the more potent S-enantiomer of warfarin. So any drug that messes with CYP2C9 can really throw off that delicate balance.
Exactly.
And lead to some unpredictable INR levels.
Got it. And there are a lot of drugs out there that can interact with CYP2C9.
Okay.
Think of CYP2C9 inhibitors as warfarin's worst enemies.
Warfarin's worst enemy.
Okay. They can significantly increase that INR.
Okay.
Putting that patient at risk for bleeding.
So which drugs are we talking about here?
Some of the usual suspects include amiodarone, atrazole antifungals like fluconazole and atraconazole, and even some antibiotics like metronidazole and sulfamethoxazole trimethoprim.
And you also have to watch out for some less obvious culprits, like some herbal supplements.
That's a good point. A lot of patients don't think to mention those.
Right, they don't always think to mention those. So it's really up to us as pharmacists to ask those right questions.
Absolutely.
And dig a little deeper.
For sure.
So we've talked about CYP2C9 inhibitors increasing the INR. Are there any drugs that can have the opposite effect?
Yes.
That can decrease the INR?
Absolutely. And make warfarin less effective.
So CYP2C9 inducers can speed up warfarin's metabolism, which leads to a lower INR, and potentially increases the risk of clotting.
Okay, so it's a two-way street.
It is.
We got to be on the lookout for both.
For sure.
Inhibitors and inducers.
Absolutely.
Can you give us some examples of those CYP2C9 inducers?
Yeah, you've got your classic enzyme inducers like rifampin, carbamazepine, and phenytoin. And again, don't forget about St. John's wort.
Oh, yeah.
That popular herbal supplement.
Right.
Seems to pop up everywhere.
It does. It seems like warfarin has a lot of friends and a lot of enemies.
A lot of interactions.
What about drug interactions with the DOACs?
Yeah.
Are those as complicated?
They're a bit different.
Yeah.
With DOACs, we need to be on the lookout for strong CYP3A4 and PGP inhibitors and inducers. These play a role in the absorption and elimination of DOACs.
Oh, so any drug that affects them can alter the drug's concentration in the body.
So similar concept, but different players.
Different players.
Can you give us some examples of strong inhibitors and inducers for the DOACs?
Sure. So for inhibitors, think about drugs like azole antifungals.
Okay, azoles again?
Yep, those azoles again.
They're trouble.
They are.
HIV protease inhibitors like ritonavir and macrolide antibiotics like clarithromycin.
Yep.
Okay, and for inducers, you got our usual suspects, rifampin, carbamazepine, and phenytoin.
Got it.
So if we see a DOAC and one of these drugs together, we need to pause.
Yes.
And really assess the potential for an interaction.
Absolutely.
Is there like a handy mnemonic or a trick to help remember all these interactions?
I wish there was.
Yeah.
Unfortunately, there's no magic bullet here. The best way to master this is through practice and repetition.
Okay.
Familiarize yourself with the common culprits and pay close attention to drug interaction resources like Lexicomp or Micromedics.
Resources are our friends.
They are.
A good pharmacist never stops learning.
Never.
Okay. We've covered the basics of VTE, the different classes of anticoagulants, the importance of recognizing drug interactions. Where do we go from here? What other Naplex-worthy pearls do our listeners need to know?
Well, there's still so much more to explore.
Oh, good.
We need to dive into the specific dosing recommendations for each anticoagulant, and that includes renal and hepatic dose adjustments.
Oh, the dreaded dose adjustments.
I know, right?
But they're important.
They are crucial.
We got to make sure we're providing safe and effective therapy for our patients, especially those with compromised organ function.
Exactly. And of course, no discussion of anticoagulation would be complete without talking about monitoring parameters.
Right. We need to know what to monitor to assess both the efficacy and safety of these drugs.
Absolutely. APTT, INR, anti-AC levels.
What else should we be keeping an eye on?
We'll delve into all of that and more in the next part of our deep dive.
This is where we'll pick up in part 2.
So stay tuned.
Until then, keep those brains engaged and those thinking caps on.
We'll see you soon for more Naplex navigation.
Absolutely.
Welcome back to the deep dive.
All right. Dosing, it can feel overwhelming with all the different agents and their unique properties and all those adjustments, but I'm ready to tackle it.
Great. Let's start with heparin. Our intravenous workhorse. Remember, weight-based dosing is key here.
Right. Weight-based dosing. So step 1 is to make sure we have that patient's weight in kilograms. Then what?
For VTE treatment, we typically start with a weight-based bolus, followed by a continuous infusion, and that infusion rate, you guessed it, also weight-based.
Okay, so we calculate the bolus dose, we calculate the infusion rate, and then we're off to the races, carefully monitoring along the way. Of course, too much heparin, we risk bleeding too little, and the clot doesn't get treated effectively. It's all about finding that sweet spot, right?
Exactly. That's where monitoring comes in with heparin. We're closely monitoring the APTT, or activated partial thromboplastin time. The goal is to get that APTT into the therapeutic range, which is usually about 1.5 to 2.5 times the patient's baseline.
Okay, so it's not just about hitting a specific number, it's about individualizing that target based on the patient's baseline. That makes sense.
Yeah.
What about monitoring for LMWHs? Do we also need to monitor APTT?
The good news is that with LMWHs like enoxaparin and dalteparin, routine monitoring isn't usually necessary.
Oh, good.
Their pharmacokinetics are more predictable, and they have a lower risk of bleeding compared to heparin.
That's a relief, one less thing to worry about. But I'm guessing there are exceptions to that rule, right? There are always exceptions in pharmacy.
You're right, there are always exceptions. There are a few scenarios where monitoring might be considered for LMWHs, for instance, in patients with renal impairment pregnancy or extreme body weight in those cases. We might check anti-AXA levels to ensure appropriate dosing.
So it's not a complete free pass with LMWHs. We still need to be vigilant and consider those special populations where those adjustments might be necessary.
Absolutely, vigilance is key. Now let's shift gears to Fondaparin X, our injectable factor XA inhibitor. It's also dosed based on total body weight, and thankfully it doesn't usually require monitoring another win for convenience.
Okay, Fondaparin X weight-based dosing, no routine monitoring. Got it. Let's move on to those direct thrombin inhibitors, starting with argatrobin and bivalirudin, our trusty HIT heroes. what's the dosing strategy for these intravenous agents?
Both are given as continuous intravenous infusions, and similar to heparin, we titrate the dose based on APTT monitoring.
So we're back to the APTT dance. Now, what about dabigatran, the oral DTI? That one seemed much simpler in terms of monitoring.
Right. Dabigatran is a fixed-dose medication, and routine coagulation monitoring is not required. It's a big selling point for patients who are tired of those frequent blood draws.
Yeah, I can imagine no more needles and poking, but even though we're not routinely monitoring, we still need to be mindful of potential bleeding, right?
Of course, just because we're not routinely monitoring doesn't mean we can throw caution to the wind. We still need to be vigilant for any signs or symptoms of bleeding and consider those risk factors that can increase a patient's susceptibility.
Right, so we're always thinking about those risk factors and educating our patients about the warning signs. Okay, let's wrap up our dosing journey with warfarin. This one seems to have a reputation for being a bit more demanding.
That's an understatement. Warfarin dosing is where things get really individualized. There's no standard starting dose. It all depends on the patient's clinical presentation, other medications, and even their genetics.
Genetics, really? You mean a patient's genes can influence how they respond to warfarin?
Absolutely. Remember how we talked about CYP2C9 and its role in warfarin metabolism? Well, genetic variations in this enzyme can significantly influence a patient's response to warfarin. Some people are slow metabolizers, meaning they need lower doses, while others are fast metabolizers and may require higher doses to achieve the same therapeutic effect.
Wow, that's fascinating. It's like personalized medicine in action. But how do we know if a patient has these genetic variations? Do we routinely test for them?
That's a good question, and it's an area of ongoing discussion. Current guidelines don't routinely recommend genetic testing for initial warfarin dosing. It's more about close monitoring and dose adjustments based on the INR.
Okay, so you start with an initial dose, monitor the INR closely, and then make adjustments as needed based on that feedback. What's the target INR range for warfarin?
The target INR can vary depending on the indication for warfarin. For most VTE cases, we aim for an INR of 2 to 3. But for patients with mechanical heart valves, the target INR might be higher, closer to 2.5 to 3.5.
So knowing those target INR ranges is crucial for making those dose adjustments. Okay, we've covered dosing and monitoring for all of our anticoagulants. What about those tricky dose adjustments based on renal and hepatic function? Where do those come into play?
Dose adjustments. The bread and butter of pharmacy practice. Let's start with renal function, interestingly. For heparin, no dose adjustment is necessary in renal impairment.
Really? That's surprising. So even if a patient has significantly reduced kidney function, we can use the standard weight-based dosing for heparin.
That's right. But for LMWHs, dose adjustment is often needed in renal impairment. It varies depending on the specific LMWH and the degree of renal dysfunction, so we'll need to consult the package insert or a reliable drug reference for guidance.
Got it. So heparin gets the green light in renal impairment, but LMWHs might need some tweaking. What about fondaparinux? Is that one affected by renal function?
It is. Fondaparinux is primarily eliminated by the kidneys. So dose reduction is necessary in patients with moderate to severe renal impairment.
Okay, another one to watch out for. Let's move on to the DTIs. What about argatroban and bivalirudin? Do we adjust for renal or hepatic impairment?
For argatroban, we adjust the dose in patients with moderate to severe hepatic impairment, and for bivalirudin, dose adjustment is necessary in severe renal impairment.
Okay, so we're seeing a pattern here. Renal and hepatic function can definitely influence the dosing of these drugs. What about dabigatran?
Dabigatran is mostly eliminated unchanged in the urine. So dose adjustment is needed in patients with moderate to severe renal impairment, and it's worth noting that patients with severe renal impairment were excluded from the clinical trials. So caution is advised in this population.
So proceed with caution when renal function is compromised now. Last but not least, warfarin. Does renal function play a role here too?
Interestingly, no dose adjustment is needed for warfarin in renal impairment.
Wow, that's unexpected. But what about hepatic function? Warfarin affects the synthesis of clotting factors, which happens in the liver.
You're right. Hepatic impairment can affect warfarin's effectiveness because it impairs the synthesis of those vitamin K-dependent clotting factors. So while there's no specific dose adjustment, we need to monitor the INR closely and be prepared to make adjustments as needed.
So it's more about vigilance and individualization than following a set dose adjustment formula. I'm starting to see a theme here, it seems like, with warfarin. It's all about that close monitoring and fine-tuning based on the INR response.
Warfarin definitely requires a more hands-on approach compared to some of the other agents, but with careful monitoring and patient education, it can still be a safe and effective option for many patients.
We made it through our dosing and monitoring marathon. We covered a lot of ground, from weight-based calculations to APTT and INR monitoring to renal and hepatic dose adjustments. I feel like my brain is overflowing, but in a good way.
That's what we like to hear. Remember, the key is to understand the unique characteristics of each anticoagulant, its mechanism of action, and its pharmacokinetic properties. That knowledge will guide you in making safe and effective dosing decisions for your patients. And don't forget to consult those reliable drug resources for those tricky dose adjustments.
Well said, resources are our friends, but before we get too comfortable, I have a feeling there's still more to discuss right off. After all, we haven't even touched on the guidelines for choosing the right anticoagulant or the duration of therapy, and those are definitely NEPLX-worthy topics.
You read my mind. Those are crucial topics, and they deserve our full attention.
Welcome back to the Deep Dive. We're in the final stretch of our Naplex Navigator journey, and this is where the rubber meets the road. We've dissected the different types of anticoagulants, their mechanisms, dosing, and monitoring. Now let's put it all together and figure out how to choose the right anticoagulant for the right patient.
This is where clinical judgment really comes into play. It's not just about memorizing all those facts and figures. It's about understanding how to apply that knowledge to those complex patient cases we encounter in practice, and of course on the NAPLX.
Right, because every patient is unique.
Yeah.
So let's say we have a patient that comes in with a confirmed DVT. What are the first things that go through your mind?
The first step is just to take a deep breath and really assess that patient's overall clinical picture. We need to consider their individual risk factors for VTE, any comorbidities that might influence our choice of anticoagulant, and even their preferences and lifestyle.
So it's a holistic approach. We're not just looking at the DVT in isolation.
Exactly. We're looking at the whole patient.
Okay, so let's talk about the CHEST guidelines. I remember them recommending DOACs as the preferred option for initial VTE treatment in most cases. What makes DOACs so appealing?
Well, DOACs offer a few advantages over warfarin. They have a rapid onset of action-predictable pharmacokinetics, and they don't require routine coagulation monitoring.
That's huge.
Plus, they have a lower risk of bleeding complications.
Okay.
This makes them a safer and more convenient option for a lot of patients.
So DOACs seem like a win-win. But you mentioned earlier that warfarin might still be a better choice for certain patients.
Right.
When would you opt for warfarin over a DOAC?
Warfarin might be preferred in patients with severe renal impairment, especially those who can't tolerate a dose reduction of a DOAC. It's also a good option for patients with a history of GI bleeds, as some DOACs have been associated with a slightly higher risk of GI bleeding.
So it's not just about which drug is better.
Right.
It's about choosing the best drug for that specific patient.
Exactly.
Taking into account all of their individual factors.
Absolutely. And don't forget about cost considerations.
Right.
Warfarin is significantly cheaper than DOACs.
Yes, that's huge, especially for patients that don't have insurance coverage.
Absolutely.
For those newer agents.
Exactly.
Cost is a huge factor, and it's something we need to be sensitive to as pharmacists.
For sure.
Especially when we're thinking about access to care and medication adherence.
Absolutely.
Okay, so we've considered all those factors. We weighed the pros and cons.
Yep.
We've chosen the best anticoagulant for our patient.
Right.
Now, the big question, how long do we treat?
That's where things get even more nuanced.
Right.
The duration of anticoagulation therapy depends on several factors, including the underlying cause of the VTE, the patient's risk factors for recurrence, and their risk of bleeding.
Okay, so no cookie-cutter approach here.
No, definitely not.
What are the different scenarios that we might encounter when deciding on the duration of therapy?
Let's start with provoked VTE.
Okay.
This means that the clot was triggered by some sort of transient or temporary risk factor, like surgery trauma or immobilization.
Okay.
In these cases, treatment is typically for 3 months.
Okay, so once that temporary risk factor is resolved, we can usually stop the anticoagulation.
Exactly.
Makes sense. What about unprovoked VTE? I remember learning that those cases are a bit trickier.
They are. Unprovoked VTE means there's no clear trigger for the clot, which puts these patients at a higher risk of recurrence.
Okay.
So treatment usually extends beyond 3 months.
Okay.
And sometimes indefinitely.
Indefinite, wow, that's a big commitment for a patient.
It is.
How do you decide if indefinite anticoagulation is warranted?
It's a complex decision that involves carefully weighing the risks and benefits for each individual patient.
Okay.
We consider their age, their history of previous clots, their bleeding risk, and their overall health status.
So lots of different factors.
Shared decision-making is really crucial here.
Shared decision-making, that's a key phrase. It's about having those open and honest conversations with our patients.
Absolutely.
Helping them understand the risks and benefits and empowering them to make informed decisions about their care.
Exactly. And those communication skills are just as important as our clinical knowledge, especially on the NAPLX.
Right.
They want to see that we can apply that knowledge in a patient-centered way.
Absolutely. It's about being more than just a walking textbook. It's about being a compassionate and effective pharmacist.
I completely agree.
Okay, so we've covered provoked and unprovoked VTE. What about cancer-associated VTE?
Oh, yeah, that's another challenging scenario.
Yeah.
Patients with active cancer have a significantly higher risk of both VTE and recurrence.
Okay.
So in these cases, indefinite anticoagulation is often recommended.
Okay.
As long as the benefits outweigh the risks.
It seems like managing VTE is this ongoing process of assessment, reassessment, and individualization.
It is.
We need to be constantly evaluating our patients,
right,
considering new information, and adjusting our treatment plans accordingly.
You said it perfectly. It's a dynamic process that requires us to stay engaged, informed, and adaptable. And that's what makes pharmacy so challenging and rewarding.
I couldn't agree more. We've covered a lot of ground in this deep dive. We started with the basics of VTE, explored the different classes of anticoagulants, tackled dosing and monitoring, and delved into the complexities of choosing the right drug and determining that duration of therapy.
And we did it all while keeping the NAPLX in mind. Remember, the goal is not just to pass the exam, but to develop the knowledge and skills to be a competent and confident pharmacist who can manage those patients on anticoagulation therapy.
Well said.
Yeah.
So what's the one key message you want our listeners to walk away with from this deep dive?
I think the key is to approach each patient as an individual, considering their unique risk factors, comorbidities, and preferences.
Okay.
Don't be afraid to consult those guidelines.
Yes.
Utilize evidence-based resources and engage in that shared decision-making.
Yeah, absolutely.
And of course, never stop learning.
Fantastic advice. And remember, this is just the beginning of your anticoagulation journey.
It is.
The learning never stops. Keep diving deep. Keep asking questions and keep striving to be the best pharmacist you can be.
Couldn't have said it better myself. Thanks for joining us on this Naplex Navigator Deep Dive.
And until next time, on the Deep Dive, happy studying.